Welcome to this satellite symposium presented by Eurofins Transplant Diagnostics. The moderator for this session is Winston Ali, Medical Science Liaison at Eurofins. Please stay tuned after the session talks for the panel discussion. If you would like to submit a question directly to the session moderator, please utilize the Q&A feature on the side panel of your screen. Enjoy the session.
Hello, and welcome to the Eurofins Transplant Diagnostics CEoT Symposium presentation titled Immunosuppression Minimization, How Biomarkers Can Play a Role. My name is Winston Ali, MSL for Transplant Genomics Eurofins, and I'll be serving as moderator for today's presentation. Our first speaker is Dr. Josh Levitsky. Dr. Levitsky is a professor of medicine and surgery in the Division of Gastroenterology and Hepatology at the Comprehensive Transplant Center at Northwestern University. He will be presenting on reverse and preserve, saving the kidney in liver transplantation. Our next speaker will be Dr. Martha Pavlakis. Dr. Pavlakis is the Medical Director of Kidney and Pancreas Transplantation at Beth Israel Deaconess Medical Center and also an Associate Professor of Medicine at Harvard Medical School. Dr. Pavlakis will be sharing a case study on immunosuppression adequacy. Dr. Sarthak Vermani is a transplant nephrologist at Yale School of Medicine. He'll be presenting the challenges of calcineurin inhibitor to belatacept conversion. Thank you.
Hi, my name is Josh Levitsky. I'm a professor of medicine at Northwestern's Transplant Center. And today I'm going to be talking about kidney injury in liver transplant candidates and recipients with specific reference to two biomarker models that can hopefully help us more objectively understand kidney injury and predict outcomes in this patient population. So this is my outline. I'm going to start off with kidney injury in end-stage liver disease patients and also briefly talk about the current simultaneous liver-kidney policy, patients who have acute or chronic kidney injury, and the use of the reverse predictive model that could help us decide on more objective parameters to predict kidney recovery after a liver transplant. And then I'll be moving into reviewing kidney disease risk in liver transplant recipients and how the preserve predictive model may help us predict patients who will have future deterioration in kidney function or not. So starting off with the pre-transplant end-stage liver disease clinical scenario, acute kidney injury is very common in patients with cirrhosis. It occurs in up to 50% of patients with end-stage liver disease and decompensation. And there's a spectrum here of acute kidney injury that is caused by multiple different etiologies. The central one that's related to liver failure is hepatorenal syndrome. And this can be severe and abrupt, which is type 1, or more protracted like type 2. But certainly that's not all of the kidney injury in cirrhosis. We do see patients with pre-renal azotemia from dehydration or fluid losses. And we also see patients with structural kidney disease, acute tubular necrosis, occasionally post-renal obstruction. And then, of course, encompassing all of this is some of these patients have underlying chronic kidney disease that's very difficult to detect. Particularly these patients who have muscle wasting and have ascites, and it's often difficult to detect chronic acuity versus chronicity, and sometimes there's overlap. So why do we care about patients with kidney injury? Well, it predicts mortality. If you look at data from the last several years, and this is just one article that presented acute kidney injury and the relationship of it to mortality in patients with cirrhosis. And you can see that the best survival is patients who have no acute kidney injury. And at every severity level of acute kidney injury, the survival in patients with cirrhosis dramatically decreases. And you can see that AKI3, which is the most severe, has very poor survival at 90 days. And we've known this for a long time. In fact, the MELD score, creatinine and GFR are highly weighted in the MELD score, which predicts 3 months mortality. So if we see patients with acute kidney injury it means that their risk of dying on the wait list is much higher. But then again, they are prioritized with the MELD score, so that hopefully we can avoid that by transplanting them sooner. So again, we care about kidney injury because of this mortality list on the wait list. And also this can progress, the longer it goes, it can progress to irreversible injury. The issue is we really have difficulty determining reversibility on a liver transplant wait list. There are clearly patients who have been on dialysis for several months that are not going to have reversibility, but more often than not, it's in an acute to chronic transition period where it's difficult to determine if the patient, giving them a liver transplant alone, is going to allow the kidney to recover, because replacing the liver improves their kidney dysfunction, mainly in functional kidney issues like hepatorenal syndrome. And of course, we all want to avoid this prolonged kidney injury after liver transplant, because this highly correlates with morbidity and mortality, particularly with advanced CKD or needing dialysis for a prolonged period after a liver transplant. The patient's survival is not very good. So it'd be ideal to predict this reversibility before the transplant so that we can best decide what organ or combination of organs to give them. And it's because of this difficulty in not being able to predict kidney injury recovery after a liver transplant that a lot of centers up until recently have decided to go with doing a liver kidney transplant because it's difficult to predict, and we're trying to avoid post liver transplant kidney failure. And so SLK numbers have dramatically increased since MELD implementation. And again, this is because creatinine is so highly weighted in the MELD score that the majority of the patients are going into transplant with kidney injury. But of course, every kidney that is taken for a simultaneous liver kidney disadvantages patients who are waiting for a kidney transplant, such as end-stage renal disease patients, and also other combined organ like heart, kidney, lung, kidney, etc. So before 2017, transplant centers, liver transplant centers, could just allocate the kidney to the liver. But because of this rapid rise in SLKs and the concern about using these kidneys in this patient population, sometimes inappropriately, sometimes the kidney recovers and you didn't need to do the SLK. The OPTN came up with allocation criteria for SLK, which is very specific. And in order to get an SLK, they have to meet one of these criteria. And I won't go through all of these independently, but CKD criteria, sustained acute kidney injury criteria, and rarely metabolic kidney disease. So that this basically put the allocation for an SLK, you had to make certain requirements. Centers couldn't just do a liver kidney. A nephrologist would have to sign off on this, and the team would have to list the patient under these criteria. And so this all was predicated under, if you made the wrong decision, you did a liver transplant alone, or at least in this case, the patient wasn't allocated or wasn't allowed to be allocated for an SLK because they didn't meet criteria, and the patient received a liver transplant alone but had kidney failure afterwards, there's something called a safety net, which allows patients at day 60 to day 365 prioritization on the kidney alone list. And we call this CALT, K-A-L-T, kidney alone after liver transplant, if you're on dialysis or your GFR is less than 20. Of course, this safety net also takes away from kidneys from other patients too. The hope with this criteria was that the SLK numbers would go down fairly significantly and only a modest increase in CALT, so that there were extra donor kidneys for other patients. However, recent data was presented at the ASLD over the last 2 to 3 years of the criteria and what has happened. And actually, if you look at the top, the liver kidney registrations have sort of stabilized, and we aren't seeing up on the top right a downtrend in SLK. We're basically seeing about the same numbers that we were before. It's not going up, but it's not going down as we had hoped. What is going up significantly is the number of kidney after liver transplants on the bottom. So right now, at least preliminarily, we're sort of shifting kidneys to kidney after liver. And so we're not really seeing a bonus or an extra supply of kidneys after liver transplant or kidneys for the end-stage renal population. And I think this comes back to can we better predict pre-transplant who really needs an SLK and who really is going to recover and not need a kidney after a liver. And this is where we hope that our model that we've developed may help here. So we started off by looking at plasma protein biomarkers in the pre-transplant phase by sending a large panel of proteins, about 16 proteins in the plasma. These were patients that we compared groups of no AKI, patients with IAKI, meaning they got a liver transplant alone, but had irreversible acute kidney injury, meaning they had low GFR after the transplant. And then RAKI means they had reversibility of their acute kidney injury after a liver transplant. And we tested these proteins pre-transplant to see if they could predict the outcome after transplant. And as you can see here, two of the ones that came out, osteopontin and TIMP1, they are actually proteins that are involved in renal recovery, were much higher in patients with reversible acute kidney injury than those with irreversible or no acute kidney injury, suggesting that these pre-transplant proteins could, if they're elevated, could forecast post-transplant renal recovery. And so we put this into a model, and we developed a multivariate regression model, which included age, diabetes, so young age and absence of diabetes in conjunction with osteopontin and TIMP1 levels being high, could predict reversible acute kidney injury with pretty high accuracy, AUC of 0.82. And you see on the left, it surpassed the clinical only model and the protein only model. So actually, if you combine those two clinical factors in the two proteins, it had the best AUC. Of course, this was quite a while ago. We published this, and this was just our center. And so we proceeded to collaborate with Baylor University in Dallas, and they had a number of samples of very identical patients pre-transplant where we used the same phenotypes. And so we took those samples and we tested the protein panel and also the model, which we at the second stage coined the model REVERSE, which is renal recovery assessment in liver transplant. And very nicely, it validated in an external cohort, in an external Baylor cohort. If you look at the bottom, these are the number of samples, and they had serum, we had plasma, but it looked very similar. And you can see that the area of the curve, under the curve, dips a little bit with the validation cohort, but quite good at predicting this recovery in the pre-transplant phase. And the other nice thing too is that when we looked at these independent proteins, osteopontin and TIMP1, there was a rapid resolution of their levels in reversible acute kidney injury, meaning as the kidney injury is reversing, TIMP1 and osteopontin levels come down abruptly compared to the other proteins. And so before I go on to the next slide, I'll finish with this, but our hope is that the reverse model could be used by clinicians in the pre-transplant phase to determine renal recovery afterwards. Now, currently we already have the SLK criteria that are set in stone. I think the potential utility here would be to try to further validate or implement this into new criteria, particularly if OPTN is relooking at their data and would like to objectify it a little better to be able to meet its goals, which at this point, it doesn't seem to be meeting the goals after the first couple of years. In addition, this may help guide immunosuppression regimens that could potentially highlight the need for renal sparing regimens in the immediate post-transplant phase, depending on their recoverability assessment. So moving to renal disease post-liver transplant, certainly pre-transplant kidney disease often predicts post-transplant kidney function, even the short term or the long term. But a lot of patients do recover, but are on calcineurin inhibitor therapy. And liver transplant has the highest rates of chronic kidney disease over the course of several years. So you can see here on this old slide from Ojo, this data even looks more significant in the MELD era. And so how can we predict patients who are going to have kidney deterioration long after their liver transplant? And so we set out to do a very similar analysis, which is look at proteins of kidney injury in post-liver transplant patients. And what we found is, after looking at this panel, that a number of these proteins on the left, and including age, a number of these factors were elevated in patients who had chronic kidney disease compared to those who did not. But these really were performed at the time of patients having CKD already. What we want to do is to be able to predict it. Are there proteins early after the transplant that could help predict the future deterioration in kidney function? So this gave us a sense of what proteins were elevated. Then we took that same panel and tested it earlier after the transplant. And this was our CEoT 14 study, an NIAID supported study, and an R21, which serially followed patients, nearly 200 patients, multi-center after liver transplant alone. And what we found is we found patients that about 89 of them who had preserved GFR above 60 at month 3, and we looked at them over the course of 1 to 2 years. And you can see on the right that the black represents stability in renal function. And then the red represents patients who had deterioration in renal function, more than a 10% drop from baseline. So you can see here there seems to be two trajectories, those who are normal and versus those who deteriorate. And this is essentially very hard to predict because they have normal kidney function to start out with. And so what we were really interested in is, are there proteins at this month 3 time period that are elevated that could predict the red group versus the black group, such that immunosuppression modifications could be made to avert going into the red group? And so we did the same thing. We sent lots of samples for these proteins, and we came up with 2, beta-2 microglobulin and CD40. These are renal injury proteins, along with hepatitis C. Now, we no longer have hepatitis C to worry about, but this model actually works pretty well if you don't have hepatitis C. And we called it PRESERVE, which is Prediction of Renal Outcomes After Liver Transplant model. And this was very predictive with an AUC of about 0.82 of renal deterioration over time, being in the red group at baseline. When the kidney function looks good, these proteins in patients who deteriorate renal function are elevated when the kidney function is good. So these are what we call sort of subclinical kidney injury proteins. Then if you look at this, some additional proteins also correlate with GFR change over time. And here you can see the beta-2 microglobulin in the middle here on the top. It certainly has a very much of a correlation with GFR deterioration. So then we said, well, it works well in this multi-center cohort. Then we went back to our Baylor colleagues, tested the model post-transplant, and we saw very close AUC of about 0.8047. that this actually validated in SERA, the model, the preserved model validated. Again, this is 3 months, 2 to 3 months after a liver transplant alone, GFR above 60. This model helps predict who is going to deteriorate renal function over time. Now, why is this important? Well, there may be something actionable. And so I'm going to finish with that. So the reverse model, again, is a pre-transplant model that helps predict post-transplant kidney injury recovery. So we hope that future criteria could potentially incorporate this model in being better able to select liver kidney versus liver transplant alone, better than, or maybe in addition to, our clinical prediction in the criteria. It's not clear, but needs to be tested if this model predicts kidney recovery in patients with a little bit longer kidney injury, or maybe in those patients who are in a CKD zone. That could, because some of these patients do have reversibility after a liver transplant. And the PRESERVE really is modeled for post-transplant. If you have a patient a couple months out from liver transplant who has a normal GFR, most clinicians will just maintain the calcineurin inhibitors at the standard levels. And we know that if that's done, like the CEoT study, there's a group that will have deterioration over time, and it's a slow deterioration. So our hope would be you could use the model, test it at that baseline, and if it's positive, meaning they're predicted to deteriorate, this would be a group to consider proactively minimizing their calcineurin inhibitor or withdrawing it over time in a safe way, proactively to avert this deterioration in GFR. Whereas if you're in the group that's negative, this may be a group that you don't want to try to minimize, and you avoid the risks of rejection with minimization when it may not be needed. So I'd like to thank Eurofins for inviting me to give this talk on these two models that we hope will be able to be implemented in practice in the near future. Thank you.
Hi. Thank you very much, Josh. That was very interesting. My name is Martha Pavlakis, and I would like to present a case study and a brief discussion on immunosuppression adequacy in the kidney transplant patient. I'm the medical director of kidney and pancreas transplantation at Beth Israel Deaconess Medical Center, and my clinical work is surrounding kidney transplantation. These are my conflicts of interest. None are relevant to the sponsors of this study or the content of this talk. So this is data from the OPTN annual report published in 2019. And I always like to start here as a good reminder of how many patients are living with a functioning kidney transplant. This is by age, but if you look in green, you can see in 2017, 2018, well over 200,000 patients in the United States are alive with a functioning kidney transplant. Now, if we look at graft survival data from that same report, you can see that for recipients of deceased donor transplants, obviously the KDPI is related to graft survival, and the high KDPI kidneys at 5 years are still working about 65% of the time. But all the other KDPI ranges, basically around 5 years, they're all working at about 80% of the time. So the good news of kidney transplantation is that there are a lot of patients out there with functioning kidney transplants. Many of them appear to be stable, but over time, as grafts fail, we discover that there is a pathology going on that possibly we didn't know about before. The case I'd like to present is a patient of mine, KR. I might refer to him as Keith because that's his first name. And at the time of transplant, he was a 36-year-old man with type 1 diabetes and end-stage renal failure. He had been on peritoneal dialysis for 2 years, and he was fortunate enough to receive a live donor kidney transplant in 2014 from his cousin. Now, this cousin was in his 30s, just like the recipient. The donor is a 4-antigen mismatch at the A and B in the host versus graft direction. There's one additional mismatch in the C if you count that. But fortunately, the donor was a 0 mismatch at both DR and DQ. So overall, it was a 4 out of 8 mismatch in the host versus graft direction. The recipient was HLA low risk, meaning they have no anti-HLA antibodies at baseline. Our approach for HLA low-risk patients is to monitor the development of de novo Dsas around the 1-year anniversary. He underwent standard induction at our center for people with low HLA risk, which is standard induction with 4.5 milligrams per kilo of antithymocyte globulin, steroids that are bolused but then tapered to off by day 7, tacrolimus, and mycophenolate mofetil. The first year postoperatively went fine. There were no tacrolimus trough levels that were outside the targeted range. There was no known medication non-adherence or no suspected medication non-adherence. He had a good creatinine in the mid-1s, and his urine protein to creatinine ratio was stable at 0.1. His blood pressure control was good, and his diabetes management was adequate. At 1-year anniversary, unfortunately, he was admitted with 2 to 3 weeks of increasing PND and orthopnea. He had acute ischemic HFrEF and acute kidney injury. Creatinine was 2.7, and he was spilling protein in the subnephrotic range. A biopsy after his ischemic heart disease was stabilized and treated showed antibody-mediated rejection, and Luminex analysis of his serum showed new donor-specific antibodies. You can see that his biopsy showed G3 glomerulitis. There was no peritubular capillaritis, interestingly, but the C4D staining was diffuse, and it was C4D grade 3. His donor-specific antibodies, actually there were 3 of them, and not surprisingly, they were all class 1, A2, B65, and the highest one was B60. Because we felt that we could pherese off these antibodies successfully, we treated him with pulse steroids, which were then continued. He was not tapered back to 0. He had 10 treatments of plasmapheresis, each one followed with IVIG, for a total of 2 gram per kilo IVIG treatment, and then 2 doses of rituximab. So if you look across the United States, the standard protocol for kidney transplant immunosuppression is induction therapy, either with Simulect or thymoglobulin, plus a calcineurin inhibitor, usually tacro, mycophenolate, and prednisone that is tapered but not stopped on average. That's the most common immunosuppression regimen. And you can look at, again, the OPTN data reports, very interesting source of data if you want to know what's happening in the country. And you can see in blue the vast majority of kidney transplant patients in the first year post-transplant, over 60%, are discharged on TAC, MMF, and steroids. And then another 30% go home on TAC, MMF, but no steroids, having been tapered to off at the time of transplant. So 90% of patients basically get a TAC and MMF with or without steroid regimen. So what are the other approaches to maintenance immunosuppression that are out there? Well, first off, like at our center, we practice a lot of steroid withdrawal. We don't do any steroid avoidance, which is no steroids at the time of transplant. Many centers practice calcineurin inhibitor minimization, or CNI avoidance by using co-stimulation blockade, or a late CNI switch to either an mTOR inhibitor or a co-stim blockade. And there are other regimens as well, but these are some of the more common alternative approaches to immunosuppression. Now we have multi-center studies to guide immunosuppression. I think that one of the reasons that the most common regimen is a TAC-MMF-based regimen is that studies have shown that to be the most successful in the short and long run in terms of maintaining graft adequacy. You'll hear a little bit more about belatacept in this seminar. The Bella series of the studies showed that with 2 different regimens of Bella compared to cyclosporin, with all 3 arms using prednisone continuation and mycophenolate, that the early acute rejection rates with Bella were actually higher, almost up to 25%, compared to 11% in the cyclosporin group. However, 2 years post-op, the GFR was up to 15 mils per minute higher in the non-CNI containing Bella regimens. Now, if you look at the presence of donor-specific antibodies, the cumulative rate in those benefit studies for the development of de novo Dsas was significantly lower with each of the Bella regimens compared to cyclosporin, 2 to 5% versus 18% at 7 years post-transplant. When these results first came out, I really wondered whether this was due to biology or to compliance. In other words, was this due to something inherent in the Bella regimen, or was this because patients were less likely to skip doses because it was a monthly infusion? This study, published a few years ago, lent credence to the idea that actually belatacept is better at controlling de novo DSA development because the Bela patients, compared to CNI-treated patients, had lower proportion of circulating effector B cells and lower B cell markers of activation, which often precede de novo DSA development. And if we go back in time to look at steroid withdrawal versus steroid maintenance regimens, you can see that the FREEDOM study really forms the basis of why programs choose to do what they do. Published back in 2008, the FREEDOM study design was one that compared standard steroid continuation with steroid withdrawal by day 7, which is what the patient in the case study that I showed you did, and steroid-free, where the patient didn't even get any steroids whatsoever. And one of the most interesting results of this study was that pretty early on, the steroid-free and steroid withdrawal patients had higher rates of early acute rejection. By day 60, these curves have definitely separated. And at 1 year post-transplant, these differences compared to steroid continuation were all statistically significant. However, many of these rejections were easily reversible, and they happened during the early period post-transplant when the patient was being maximally monitored. Late steroid withdrawal really never got off the ground. This is an old study from Asan and colleagues, which had a late withdrawal of steroids, and the study was actually prematurely ended because of the increased risk of bad outcomes, including acute rejection rates that were higher, especially in Black patients, and higher creatinines in the steroid withdrawal group. So this begs the question, how do we monitor allografts, and is this monitoring adequate? Of course, we look at function, creatinine, proteinuria, and some centers do protocol biopsies. We don't happen to do protocol biopsies, but we have a low threshold to biopsy. But still, that's not something that can be done frequently enough to really be considered a monitoring tool. And then we think about the immunologic status. So we test for development of de novo donor-specific antibodies post-transplant on a set schedule. Like I said, for the majority of patients who are low HLA risk, that first test happens 1 year post-op. And the question is, what is the role for some of these newer tests? ATP response to stimulated peripheral blood lymphocytes, donor-derived cell-free DNA in the blood, gene expression tests. What the role for these in monitoring of allografts, in my mind, really has not been established. We all know how anti-HLA antibodies are tested for. With beads, HLA-specific IgG antibodies bind, and then those bound antibodies are labeled, and you get a readout. How often do de novo DSAs develop? Well, this really interesting study by Wiebe et al. Looked at over 500 renal transplant recipients who were all low HLA risk at the time of transplant. And you can see that over 12 years, up to 27% developed de novo DSAs. Now, what the investigators did in this study is they went back and looked through who developed de novo DSAs and whether or not the people that did had any indication in their chart that there was some non-adherence to medication. And you can see if you divide the patients who developed de novo DSAs, the percent fell to 19% in the medication adherent patients, but 72% by 12 years in the medication non-adherent patients based on chart review. So obviously the development of the de novo DSAs generally goes along with medication non-adherence. Now, if you go back to the case I presented, we had absolutely no suspicion of non-adherence by any measure whatsoever. The DCAF studies also gave us an interesting glimpse into kidney transplant long-term success. There was the prospective study, which was almost 4,000 patients successfully engrafted at 7 centers and followed in the long term. And what they concluded was that the transplant was relatively stable until something happened to change the equilibrium. Early events at the time of transplant and demographics they found were relatively poor at predicting late outcomes. So what's a transplant nephrologist to do? So back to the case presentation, this patient had the AKI fully resolved and the proteinuria improved but did not disappear. I repeated a biopsy on him 3 months after the completion of treatment, and the results were almost identical. He still had glomerulitis, he still had C4D deposition, but there was more signs of transplant glomerulopathy. hence the proteinuria. He eventually underwent 4-vessel CABG, which is complicated. He had slow deterioration of function and eventual graft loss that began 1 year post-op in this very promising transplant in a very medication-adherent patient. Good news, 2 years ago, he underwent a simultaneous pancreas kidney transplant. He has good function, and he's doing very well with careful monitoring. Now, most patients don't have antibody-mediated rejection. Most patients, when we look at them, are doing quite well. They may be suffering from other comorbidities, and we're doing a lot of careful monitoring. Our usual monitoring tools for the health of the kidney are limited. Newer tests like cell-free DNA that correlate with antibody-mediated rejection, in my mind, are limited in terms of monitoring stable patients. And what we need really is a test to confirm or refute stability when the other tests all look good, when the creatinine is fine, when there's no proteinuria, when there's no de novo DSA development. So we need a better non-biopsy way to survey a kidney that appears stable by our usual metrics. We need a test that can tell us if the patient is stable, and more importantly, if they're over or under immunosuppressed. Just because all patients are going along and the monitoring shows they're well, doesn't mean that they all need that degree of immunosuppression. Some, like our patient in the case presentation, clearly needed more to block the development of the de novo DSAs. Other patients are over-immunosuppressed and are at increasing risk for long-term negative outcomes due to this. So can we use information to lower or raise immunosuppression in otherwise stable patients to improve their outcomes? When it comes to these non-invasive tests, I'm less interested in a test that correlates with our clinical findings and our clinical suspicion. I'm more interested in a test that can give us insight into how an otherwise completely stable patient is doing so that we can both anticipate bad outcomes and, more importantly, do something in advance to ameliorate them. And with that, I thank you very much and turn it over to Sarthak.
Hello, everyone. My name is Sarthak Vermani, and I'm one of the transplant nephrologists in the section of nephrology in the kidney transplant program here at Yale School of Medicine. And I'll be talking to you in the next couple of minutes about some of the challenges we face when we convert our patients' immunosuppression regimen from a CNI-based regimen to a belatacept-based regimen. I do not have any financial disclosures. And as we all know, that calcineurin inhibitors have formed the backbone of immunosuppressive therapy regimens in most solid organ transplantations, especially kidney transplants, since their FDA approval a couple of decades ago. But this has come with their own sort of fair share of challenges. Just to go over a few of them. So chronic allograft nephropathy, which was initially sort of thought to be just chronic immunological injury in the setting of chronic antibody-mediated rejection, has taken a new spin to it with the inclusion of chronic vasoconstrictive kidney injury or allograft injury contributing to it as well. Neurotoxicity and cognitive issues are common in patients on tacrolimus therapy, and it's thought to be due to neurovasoconstrictive issues as well. Thrombotic microangiopathy is known to be present in patients who are undergoing who have tacrolimus as their immunosuppressive regimen. Tacrolimus or other CNIs obviously worsen the metabolic disturbances in our already sort of metabolically compromised patients, worsens hyperglycemia, leads to worsening post-transplant diabetes mellitus, and eventually leading to worsening cardiac events. Hypomagnesemia can be very, very stubborn in these patients, and often we have converted our patients from tacrolimus to belatacept just because of profound, persistent hypomagnesemia and its subsequent effects. Cosmetic concerns depends on what CNI you're using. You can have hirsutism, you can have gingival hyperplasia, and it's not really a popular drug with a lot of the younger folks for that same reason. Not everyone tolerates the drugs as comfortably as the others. A lot of them experience a lot of GI intolerances, a lot of diarrhea, which sort of makes them enter this vicious cycle of worsening drug toxicities. And as always, like any other drug, pill adherence is always an issue as well. So with all of these issues at hand, the upcoming of belatacept in 2010 was really exciting news for most kidney transplant physicians, and which was first described in 2010 in AJT in the benefit trial. And this the data that I'm showing right now is from the 7-year follow-up, which was published in New England Journal of Medicine, of showing the belatacept and long-term outcomes in kidney transplantation, that not only at the 12-month mark, but all the way down to the 84-month mark, which is about 7 years later, the mean eGFR was still superior in patients that were using belatacept maximal intensity or lower intensity regimens as compared to cyclosporin, which was the CNI of choice in this study. Going back to the original benefit trial, and as Dr. Pavlakis also just mentioned, not everything was rosy with the belatacept therapies. It was noted that the incidence of acute rejection was much higher in the belatacept group at the 12-month mark as compared with the cyclosporin group. In fact, the numbers here, so this is the maximal intensity, the lower intensity, and the cyclosporin groups lined up side to side. And the numbers were as high as 22%, 17% in the belatacept group as compared to about only 7% in the cyclosporin group. It's interesting to note that most of these rejections happened in the first 90 days or first 3 months, and almost all of them occurred in the first 6 months after the conversion from cyclosporin to belatacept. And a major chunk of them were BAMF grade 1A, 1B, or 2A. When you look back at what exact kind of rejection these patients suffered. What I find interesting is, despite the increased episodes of acute rejection in the first 12 months, the mean measured GFR at the end of 12 months in the original benefit study was still higher in patients using belatacept rather than cyclosporin. In fact, in whichever arm of belatacept you were and you experienced more rejection episodes, the one as depicted in gray bars here on the left 2 bars, your GFR was still higher than the cyclosporin group without any acute rejections at the 12-month mark. And maybe that has to do with something, as Dr. Pavlakis just mentioned, with decreased DSA formations as well in patients undergoing belatacept therapy. And that's depicted with this line, as I was just saying, that the GFR in the patients on belatacept with acute rejection was better than patients on cyclosporin without acute rejection. And that played out over the next 7 years. It was not just the first 12 months. This is a Kaplan-Meier curve from the New England Journal study from 2016 that we just talked about, which shows the probability of patients and graft survival charted across the time since transplant. And you see that if you play it out until for at least 7 years out, you still had a benefit of using belatacept over cyclosporin. Which brings me to our center's experience with the conversions. Now, as we just discussed, not everything is rosy with the belatacept conversions. And yes, we did see some acute rejections as well. But prior to that, the reason, so this was an initial review of the patients that we converted from cyclosporin to Bela. This was the first 80-odd patients that we reviewed the data back on. And the reasons for conversion, as you can see, are the ones that we just talked about, mostly hyperglycemia, muscle cramping from hypomagnesemia, diarrhea and GI intoxicities, alopecia or cosmetic issues, nephrotoxicity, which is defined as sustained acute tubular injury on multiple biopsies with no other identified factor. It was thought to be due to the vasoconstrictive effects of the CNI. But the most common cause for transition from CNIs, from Prograf to Bela, was the neurotoxicity. And we were seeing a lot more of our patients complaining of tremors and a lot more cognitive decline, feeling foggy, feeling forgetful. And that seemed to be the most leading cause, at least at our center, for transition from tacrolimus to belatacept. And in fact, we saw such a large number that we actually started a next sort of study at our center called the CAB trial, or the cognition after belatacept conversion, where we used standardized NIH tools and MOCA exams and many mental status exams at time 0 at belatacept conversion and a couple of months out of belatacept conversion to see what was there an actual effect of transition from off of CNI to Bela. And that data anecdotally is very, very exciting and encouraging. And I know it's due to be published and discussed in the near future. So I'm going to leave it at that. So what about the Yale experience here? How do we transition patients from any CNI regimen to belatacept? Obviously, they need to be intolerant of the CNIs. We look for appropriate reasons or indications for switch to Bela. Recipients should be EBV IgG positive to prevent, to abate the risk of Bela-associated PTLD. Routinely, we like for the patients to be more than 3 months post-transplant, unless there is an absolute reason for them to be transitioned off of CNI, like TMA, which requires a much more expedited transition from CNIs to Bela. They should obviously have adequate IV access, which sometimes becomes a problem with our patient population with a very long dialysis vintage and vascular issues. They should have reliable transport to and from the infusion facility. To make that a little bit easy, we actually have provided belatacept infusions in at least 4 of our satellite clinics above and beyond our main hospital to help our patients with that issue. And obviously, it needs to be financially cleared by insurance of the patient. So how do we actually do it? Well, we start with the dose of 5 milligrams per kilogram body weight of belatacept, rounded to the nearest 25. We give them an induction dose that is induction dose of 6 doses for every 2 weeks, followed by a maintenance dose every 4 weeks. What do we do with the tacrolimus? Well, the tacrolimus or the cyclosporin, whichever the CNI of choice, it is reduced to half at the second dose, which is the 2-week mark, and then it's completely tapered off at the third dose, which is the 4-week mark. And again, if the reason, it depends on what was the etiology and the reason for transition, and if it was a tacrolimus-induced TMA causing graft injury, we expedite the transition off the CNI as well. What do we do once we convert them? Well, once we're converted, our protocol here suggests that we should perform a metabolic profile, either basic or comprehensive, every other week for the first couple of weeks. The clinicians are they're requested to consider biopsying prior to conversion based on the immunological risk of the patient. Again, the team can consider a protocol biopsy or a surveillance biopsy for graft health 6 months after conversion. And obviously, if we see any sort of signs of graft injury, as in elevation in serum creatinine, we can perform a biopsy for cause. We like to check the donor-specific antibodies prior to conversion, and if we see an elevation in serum creatinine at that time as well, and obviously, like any other infusion, we like to monitor the patients for any adverse effects, idiosyncratic effects to the belatacept infusion per se. So what did we find? This is unpublished data. This is almost like internal quality control data. We have about, give or take, about 300 patients on belatacept-based immunosuppressive regimen, of which we have reviewed the data for about 288 of them. And unfortunately, about 10% or about 28 of them have had at least one episode of biopsy-proven acute rejection in the first year. What is the mean time to diagnosis? It was about 135 days until we got a whiff of the allograft not being quite healthy, whether that was an elevation in serum creatinine or new Dsas that were found. And of the 28, 16 of them, which is about 57 to 60% of them, had the biopsy-proven rejection in the first 6 months as well. And this is pretty similar to what we knew going into these conversions, as was described in the initial benefit trial as well, that early on after conversion, you do see an increased risk of acute rejections in these patients. So clearly that brought us to a need to identify some sort of non-invasive monitoring even before we have clinically apparent rejection. We needed an early warning sign, especially in that early transition phase from cyclosporin or tacrolimus-based regimen to a belatacept regimen. And that's where we've been starting to use the peripheral blood gene expression testing a little bit more. This was first described by the Northwestern group in the CEoT 8 trial, and then again was commercially made available and validated as per the data provided by, I think it was Dr. Chris Marsh and group of about 7 different centers in the US that was published in 2019. But what it's supposed to do, it's supposed to replace the protocol biopsy, and it's supposed to pick up silent and subclinical rejections. Now, when you send out these gene expression testings, it helps you to differentiate between TX and not TX. TX being immune quiescence or adequate state of immunosuppression, and not TX being suboptimal immunosuppression or immune activation leading to graft injury. So a little word about the gene expression testing that we are using here. So that was, as I said, that was developed at the Northwestern University by Dr. Friedwell and his group, with data published in AJT in 2018, and subsequently validated and commercially made available based on the data by Dr. Marsh in Transplant Proceedings in 2019. When is it appropriate to use this test? The patient's creatinine needs to be less than 2.3. There should be less than 20% fluctuation in serum creatinine over the past 3 measurements. And that's to take a pause there and just to sort of reiterate the fact that this test is not the optimal test for evaluation of an allograft AKI, but instead it's the best test for surveillance of immune function. And that's what kind of, that's a situation in which we kind of use this test. When you look at the data that's presented by Marsh and group, it has a pretty decent specificity of 75% and up to 91% negative predictive value, which really gives us a lot more confidence in avoiding multiple biopsies in situations such as this immunosuppression conversion from one regimen to another. So what do we propose? We are now proposing that, we identify patients that are appropriate for conversion from CNI to Bela-based regimens, whatever the reason may be. And they get the induction doses, the 6 induction doses of belatacept every 2 weeks. And at the end of that brings you up to about 12 weeks, we should perform a peripheral blood gene expression testing and, sort of monitor what the immune system is doing and get an idea whether, there is transplant excellence, as in TX, or non-transplant excellence. And if it is transplant excellence, given that at least at our site, the highest risk of rejections was in the first 3 months or so, we could keep repeating it every 4 to 6 to 8 weeks, until you're sort of out of the window of danger, so to speak. And if it's not transplant TX, well, that gives you some more leverage to go ahead and do the biopsy and look for the rejection and, treat any allograft injury, whatever they may be. Now, there is more utility in those patients who may have a higher immunological risk. It's worth getting a baseline gene expression testing even before the conversion, so you have an idea on where you're starting, and make sure that you're not already in trouble before you're transitioning the immunosuppressive regimens. So to give you an example, we have a beloved Mr. F. He's a 69-year-old male, and he had end-stage kidney disease due to diabetic nephropathy, and who underwent a deceased donor kidney transplant, which was complicated by delayed graft function. Now, his early postoperative period was complicated by recurrent allograft AKIs, and in evaluation of which he was biopsied at least twice, and both times he had acute tubular injury with no evidence of rejection. And looking back, his acute tubular injury was mostly in the setting of hemodynamic issues because of his congestive heart failure and critical aortic stenosis. So to fix the aortic stenosis, he underwent a TAVR 4-month post-transplant and subsequent stabilization of creatinine. And his creatinine was near normal with no issues at all. And obviously, in that setting, he was anticoagulated and was apprehensive about any repeated biopsies that he may need. But he was maintained on a tacrolimus-based regimen, and there was consensus amongst our group that he's a prime candidate to be transitioned over to belatacept. And before we did that, we wanted to do a gene expression testing, which actually showed not transplant excellence, and thereafter he was biopsied, taking into account the risks of bleeding because he was an anticoagulation. And his biopsy actually showed a BAMF ACR1A rejection, which he was treated for. And now the plan is to repeat a gene expression testing and sort of, go through the algorithm that we just talked about and transition him to belatacept with serial monitoring using just this gene expression testing non-invasively in his case especially. Well, we're still learning how to use these tests. We would love to optimize the use of these non-invasive monitoring of immune system and rejection. We would love to expand its use within our armamentarium. But there are a lot of new tests available in the market, as all of you are aware. There's some that use donor-derived cell-free DNA technology, and some of them are the gene expression testing, as the one I just talked about. We need to figure out, and we need to realize what is the question we're trying to answer. Some tests, such as the donor-derived cell-free DNA, may be better in evaluating allograft AKI in the presence of donor-specific antibodies, versus the gene expression testing might be better off in evaluating or establishing immune surveillance in patients who have a creatinine less than 2.3 with less than 20% fluctuation in the creatinine. So to pick and choose the right test to answer your question seems to be the next best skill set we need to acquire. The other sort of issue we get into with these tests are insurance authorizations. At this point, Medicare is covering most of these tests, but we're running into a little bit of a roadblock with some of the private payers, which includes a very long and strenuous prior authorization process. We hope that these tests become more cost effective and more easily available to a lot of our patients downstream. And then, as I said, this is always it's always a learning curve. It's an ongoing assessment of how each of these tests contribute to hard outcomes of graft survival in the long-term follow-up. And with that, I'd like to thank you for this opportunity to give this talk, and hope to hear from you.
All right. Thank you so much. Are we live? Okay, thank you so much. All right, well, Martha, Josh, Sarthak, can you guys hear me?
I can.
Yep. Hi.
See you.
There we go. Now I can see you. It was silence on my end, so all right. Great talks, everybody. I really appreciate it. So we have a couple questions in from the chat. I figured we'd just start with those. First question was, I think it's directed, I guess it could be directed to both Dr. Vermani and Dr. Pavlakis. Do you have a cutoff PRA for switching to belatacept for your patients?
Dr. Pavlakis?
We do not. I don't think we have as formalized a protocol as Dr. Vermani does, but I would consider it for anyone, no matter what the pre-transplant PRA was.
So at our site as well, we do not have a CPRA cutoff to transition. We do have a protocol we follow during the transition, but we just look at overall immunological risk, and that's why we talked about doing these tests to kind of get a better idea who's at a higher risk and who's at a lower risk.
Okay, great. All right, next question from the chat here. It's about Dr. Vermani, your patient case. What was the ethnicity of your patient, and was he on prednisone? And then the follow-up to that is, do you use cell-free DNA prior to conversion to Blatacept?
So he was Hispanic. He is Hispanic, and he was on prednisone because he had already suffered a rejection in the past. So, initially he was prednisone tapered or prednisone free, but then he was on prednisone at the time of our evaluation. And then do we use cell-free DNA prior to conversion to Bela? No, we do not.
Okay, thank you. All right, Dr. Levitsky, so a question for you. Do you think that anything has changed in the recent era since the papers were published for preserve and reverse that would affect the applicability of these models now?
Yeah, that's a good question. When we did these initial studies, even up until recent, especially with biorepository collections, about 30% of the patients had hepatitis C. And so if you look at the current population, that population is rapidly shrinking in terms of going into transplant and also particularly coming out of transplant with very low rates of recurrence. In fact, almost never see recurrence anymore because of antiviral therapy. So I would say that would be the one population that is different, or how it is now compared to when we developed these models. What I'll say about that, though, is we did test the models taking into account hepatitis C as a variable. It was not important as a variable in the reverse model, which is the pre-transplant model. But in preserve, it actually is a variable that's included. And when we looked at our population that was hepatitis C negative, where you just put it in the model as negative, the prediction of renal deterioration still is validated in the hepatitis C negative population. But I do agree that moving forward, these models, our patient population may be a little different overall compared to when the models were developed. And we're going to, again, keep monitoring to make sure that they're as predictive as they were in the past. But I would say that's the probably biggest change.
Okay, great, thank you. Let's see, what else we have? All right, another question from the chat. So was there any changes in the BK viremia with conversion to Blatacept? So either falling or rising titers, and I think either Dr. Vermani or Dr. Pavlakis, if you'd like to address that. So, and changes in BK viremia when you've done your conversion.
So that is not something I've seen as a problem, partly because I think, like at Yale, we do conversion sort of a little bit later. But even when we've done it early for inadequate falling of creatinine or prolonged DGF, we have not seen the complication frequently of BK viremia any more than we do in the patients that aren't on belatacept.
Great, thank you. Dr. Vermani, do you have anything to add to that?
You may be on mute.
So
there you go.
That's better.
Hi. Yeah. So the patient that I talked about did not have BK viremia, but just anecdotally, we are seeing a slightly positive trend on opportunistic infections in our Bela transition patients. Now we're trying to figure out, why that is. Is it just completely anecdotal and coincidental, or is there any physiology-based thing? There might have been some concerns about acute rise in PJP cases, and maybe it had something to do with, the belatacept infusion and all of those clustering together during the infusion. So we're actually looking in that with our infection control team here, and I don't think that is related to the belatacept physiology per se, though.
Let's see. So, Dr. Pavlakis, in your presentation, you mentioned the need for additional testing options for patients that have stable renal function. So how would you incorporate TrueGraph gene expression testing for these patients that Dr. Vermani introduced in his talk?
You know, in several ways, I think it's very important to have a test that reflects stability beyond our usual methods of monitoring. Dr. Heger mentioned in a talk earlier today a study from Italy in 2015 by Dr. Ravioli, I think, in liver transplant patients. It was a beautifully designed study. Basically, it was a prospective randomized study that was designed to assess the clinical benefit of adjusting immunosuppressive therapy based on the results of an immune function assay. And it was compared to a control group where the immunosuppression was adjusted based on clinical standard of care. And that is the kind of study that we need to really let us know whether these stability tests, like the ones from TrueGraph, can actually be moved into the next phase, not just as gee, the patient has TX, that's reassuring, but can we do an intervention based on it? I know the case that I presented was of somebody who seemed to be doing well, but was ultimately, in retrospect, likely under immunosuppressed. So that person might get a non-TX result if we had been doing monitoring with this test. But just as easily, you could fathom doing it in people, say, 5 years out who are rock stable, and potentially as a study, lowering immunosuppression based on a TX result, and then following up to see how they do. I know for a fact there's a certain population of our stable patients that are over immunosuppressed. And of course, over time, they accumulate the morbidity and even mortality of the consequences of that over immunosuppression. So I could, off the top of my head, design 3 or 4 studies that would really prove the utility of this sort of monitoring, or not. But I think to really move it into widespread clinical use, we need some study where there's an intervention. So like the study from Italy in liver transplant patients, I thought that was beautifully done and really instructive.
Thank you. That's great perspective.
I'm well aware of that study. It was interesting, actually. They were able to show, I believe in that group, by using the immune function assay as a guide to reduce infection rates. By proactively minimizing immune suppression. So I think predicting rejection, though, I think was hard in that study. So having more specific immune tests would be advantageous. And we're actually, as a preamble, I didn't discuss it, but we did a very similar study that John Friedewald did in liver transplants. So we're developing a TrueGraph liver test for liver transplant patients that would have somewhat similar applications for that you're mentioning, Martha, in minimizing immunosuppression. Easier to do in liver than in kidney, though, I think.
Right. Is it the same gene profile, or is it a different test?
Same technology, blood mRNA expression. This was published in AJT in 2020. CEoT 14. It was the liver accompanying liver study to CEoT 8. But it's a different set of genes.
Got it.
38 genes, and so that's sort of in development now, is to eventually bring it to the commercial space.
Interesting.
Okay. Josh, another question for you. So are there any, as it relates to the PRESERVE study, are there any more data points further out than the 4 weeks post-liver transplant time point at this time? And do you think there would be any utility in checking in at different time points further out?
Yeah, it's a great question. I think the way that we designed the study was to get a point where liver transplant recipients have kind of stabilize their kidney function afterwards. And I think sometimes even at 4 weeks, they're sort of recovering post-operative kidney injury is still occurring. And also that's a time point 2-3 months out where immunosuppression modifications, more aggressive, would be a little safer. So we picked that time point, and also because we had additional samples from the Baylor cohort that had those same time points that we could cross-validate. So right now we've really just validated on a single early time point 2 to 3 months out, but whoever asked that question is absolutely spot on in that certainly future studies looking at perhaps earlier, perhaps a little later. It's hard to find the sweet spot of where to perform a test, but I think in that 1 to 6 month range, so that you would have the ability to detect someone who is at risk for renal deterioration and be able to make a modification, perhaps in immunosuppression, early enough to impact that outcome. If you try to do it too late, it's probably not going to work very well. And if you try to do it too early, it might be too high a risk of rejection in an intervention like CNI minimization or withdrawal. So I think that's sort of where we chose the time point, but certainly additional time points could also be looked at too.
Yeah, it's very interesting. So Dr. Vermani, a question came up for you. So in the patient case you mentioned, and then kind of the protocol you outlined for your belatacept conversion monitoring, if you get a NOT-TX on that baseline gene expression test, how long would you wait to convert somebody, do you think, if you got that NOT-TX?
I mean, first of all, can you guys hear me again? Sorry.
Mm-hmm.
Okay. So first of all, if we get the NOT-TX, we proceed with the biopsy. That's our step to the biopsy, and sort of treat them through the rejection. And at least we wait for about 4 to 6 weeks until their end of the steroid taper that they may get, and probably repeat the true graph again and see we will transition them only if it's transplant TX, not to do it when it's not TX.
Okay, great. Okay. Thank you. Let's see. Dr. Pafakis. So another question here. So in your patient case example, there's a patient that talks about like failed graft immunosuppression management. So how different is that for your patients, and how do you envision applying the test like TrueGraph in that scenario in a patient who may be kind of chronically at the same creatinine?
Right. So often when somebody has a failing allograft, if that's what the question is about, and the allograft is doing poorly, we sort of switch over to immunosuppression really to prevent end-stage rejection, immunosuppression to prevent sensitization, but we're not really thinking immunosuppression for long-term graft function. But we have no good way to monitor that. Many people come up with their own protocols. There was a nice survey study by George Bayless a few years ago showing the variety. It was a survey study showing the unbelievable variety of how people approach a failing allograft in terms of tapering immunosuppression. So while we have wonderful protocols for initiating immunosuppression at the time of transplant, and we have randomized controlled studies to, look at specific drug regimens and combinations of drugs, the tapering down of immunosuppression as a graft is starting to fail really is not standardized, it's not protocolized, it's not guided. And I think this is another situation where a test to help us actually taper immunosuppression would be very useful. Yeah.
All right. Thank you. Last question then. I think we have about less than a minute left. So in Dr. Levitsky, you mentioned that the TIMP1 and OPM levels drop off in the setting of renal recovery post liver transplant. Do you think that patients could be targeted for lower CNI doses if their levels remained elevated? So kind of the converse, if they didn't drop off, do you think there's any application to that?
It's a great thought. We have not studied that. That would definitely, and I think that those are the types of things where additional uses of the model could be applied. I mentioned sort of a renal sparing approach in patients predicted to be irreversible or not recover. Would be a very attractive study to do to sort of personalize the management instead of just kind of one size for all. You could target those who have a predictive model of non-recovery for a different immunosuppression approach. So whoever asked that is also thinking exactly how we're thinking about the applications here. So thanks for the question.
All right. Thank you, everybody. Really appreciate these wonderful talks and the great questions.
Thank you.
Thank you.
Thank you. Nice to see
Thanks.
you all.